Imagine Mary's delight when, after years of trying, she finally became pregnant. She was a fit, healthy, slightly overweight 30-year-old, and she couldn't wait to share her fantastic news with the world. All seemed to be going well until the later stages of her pregnancy, when the community midwife noted that she'd become hypertensive. However, urinalysis was not performed, and no medications were prescribed. A few days later, Mary developed some vague abdominal pains, although she was still able to go to work. When she returned from work, this pain was becoming worse and was located in the right upper quadrant, and she was really feeling unwell. She tried to relax with a cigarette and a glass of wine, but within a few hours, she had started to feel short of breath. Really short of breath. Then, she developed a severe and blindingly painful headache. When her husband got home, she was becoming confused. He was understandably worried and called for an ambulance. Unfortunately, before the ambulance arrived, she had had a seizure and never recovered consciousness. Despite attempted resuscitation and an emergency caesarean section, both mother and baby died. The coroner's inquest, following post-mortem, described marked brain edema and an associated brain hemorrhage. The coroner also made a diagnosis of eclampsia, which was stated as the primary diagnosis on her death certificate. We will consider this case and how the events unfolded.
My name is Adrian Wills, and I'm a neurologist with a special interest in stroke and maternal medicine. I want to unpack Mary's case and talk to you about the relatively common diagnosis of preeclampsia and the most infrequent but very serious problem of eclampsia.
In the United Kingdom, preeclampsia occurs in about 1 in every 32 pregnancies, and eclampsia complicates about 1 in every 4,000 births. Preterm delivery is the most common problem associated with eclampsia, but of those diagnosed, about 0.25% will die, a tragic consequence that accounts for about 3% of all maternal deaths in the United Kingdom. Fortunately, maternal deaths are rare, occurring with a frequency of 11 per 100,000 live births. In short, eclampsia results in about 8 to 10 deaths every year in the United Kingdom.
Here is the bottom line. We need to know about the preeclamptic state, recognise it when it occurs, and manage the condition as best we can. If the situation when nearing term deteriorates, we need to act fast to manage a safe delivery. Delivery is the only cure for eclampsia.
Preeclampsia and eclampsia are a spectrum of disorders. The causes for these pathologies are not entirely understood, but problems with the placenta do seem to be central and research is ongoing. Preeclampsia usually affects women in the 3rd trimester of pregnancy. It is rare before 20 weeks.
We need to start with a definition. Eclampsia means to strike by lightning. This word is derived from the ancient Greek eklampsis, which means a bright light like lightning, and describes a fit or a tragic condition of violent onset. Certainly for Mary, this was her fate, and sadly, this fate is almost always heralded by a well-defined constellation of preeclamptic clues. Preeclampsia is traditionally defined as gestational hypertension with new onset proteinuria.
However, that is actually a narrow definition, but in a basic teaching program such as this, it is a useful starting framework. We should be aware that in modern-day clinical practice, there is a broader spectrum of hypertensive and metabolic disorders that influence pregnancy outcomes. As such, other parameters, such as fetal growth rates as determined by ultrasound, vasogenic biochemical markers of placental health, indices of coagulation, liver and kidney function, are all part of the diagnostic and monitoring process. However, at this juncture, we will keep our teaching simple and focus on the traditional and narrower definition of preeclampsia, gestational hypertension, and new onset proteinuria. Gestational hypertension is high blood pressure becoming apparent in the second half of pregnancy. Most would regard a blood pressure consistently recorded above 140/90 mm of mercury as being significant. The higher it is, the more concerned we are. Proteinuria is defined as the detection of new onset protein in the urine. A urine dipstick test with 2 pluses of protein is of concern, and a significant nephropathy is assumed by the finding of at least 0.3 grams of protein in a 24-hour urine collection. However, in most clinical centres, this index has now been replaced by a simpler measure of the ratio of urinary protein to creatinine. A urinary protein to creatinine ratio equal to or greater than 0.3 is considered significant, although absolute thresholds are not defined and proteinuria can increase throughout pregnancy. The bottom line is that with any proteinuria, end organ kidney damage is assumed, and by inference, other pathologies are considered very likely to be present. If we focus on the more traditional core definition, we can state that preeclampsia describes a situation where these two red flag signs of high blood pressure and proteinuria are associated with adverse pregnancy outcomes. We should also be aware of a hatful of risk factors for preeclampsia. For example, having had preeclampsia in a previous pregnancy increases the risk 7-fold. Likewise, pre-existing hypertension increases the risk 5-fold. Similarly, with diabetes and obesity, there is a 3-fold increased risk of developing preeclampsia in the later stages of pregnancy. That is why identification of the two red flags, gestational hypertension and proteinuria, are such an important part of the antenatal care process. Trying to prevent eclampsia begins in the antenatal care setting. From here, bad outcomes can be divided into those events that happen to the mother and those that happen to the child. For the mother, the risks are those of increased anxiety, hospitalisation, an eclamptic catastrophe, and future impoverished cardiovascular health. For the baby, there is a risk of preterm delivery, low birth weight, and stillbirth. Let us consider how we might reduce the likelihood of all these bad outcomes.
Once we have diagnosed preeclampsia, an honest and realistic perspective of risk must be shared. This is really, really important. Creating fear and terror is appalling, but so too is trivialising the risk.
As such, a mother-to-be needs to be fully aware that there are risks for her and her baby. She needs to know what these risks are and what can be done to minimise them. A calm and candid conversation needs to happen and be repeated and expanded upon where necessary. Furthermore, her support group, that is her partner, family, and all other relevant people, should be made aware of her special situation. Monitoring her own blood pressure at home will enable her to be more in control of her situation and may tighten the relationship with her midwives. And she needs to know that she should not ignore symptoms should they develop.
My advice is to embrace all opportunities for calm. Avoiding stressful situations is easier said than done, but being supportive and encouraging the implementation of major lifestyle modifications is my general position. This may mean changing work duties, calling on friends for extra help at home, and limiting other commitments that are known to generate anxiety and fatigue. In the first instance, taking time out to rest, read, and maybe even to meditate is a strategy that I encourage. Likewise, should the expectant mother develop any symptoms such as headaches, abdominal pain, shortness of breath, or swelling of the face or upper extremities, then she needs to take action.
In addition to these symptoms of concern, the mother should also report any concern she may have regarding the movements of her baby. Any perceived reduction in fetal movements is also a call for her to act. And then there are medications that have been shown to be of benefit in reducing the adverse outcomes of preeclampsia. First, aspirin has been shown to reduce many of the associated untoward vascular events. Starting from as early as possible in the pregnancy, a dose of 150 milligrams is a recommendation based on the results of randomised controlled trials. Antihypertensive medications also play an important role. Blood pressure control can be improved with a variety of medications, but there are always concerns regarding the balance of risks and benefits. It must be acknowledged that many expectant mothers are not keen to take medications. That is understandable. Drugs can and do cross the placenta, and overzealous treatment can impair placental function. However, the benefits and risks can be quantified, and it is important that we offer a perspective on using medications to minimise bad outcomes.
The effect of treating preeclampsia with antihypertensive medications on pregnancy outcomes has been assessed in several ways. First, there are several large prospective studies such as the Control of Hypertension in Pregnancy or CHIP study. In addition, prospective randomised controlled trials, such as the 2 large HIPPOTAP studies, have been conducted in recent years. Finally, there are numerous observational reports with not too dissimilar findings. Continued and accruing evidence constantly reshapes the guidance of professional obstetric associations throughout the world. The following statements are reasonable.
First, while treating hypertension in pregnancy probably has little impact on the likelihood of an eclamptic catastrophe, such as a fit for the mother, small reductions in cerebral hemorrhage and maternal mortality have been evidenced. A small proportion of women with gestational hypertension do go on to become hypertensive after pregnancy, although it is unknown if treatment during pregnancy ameliorates this risk. However, there is much more compelling data to show that pharmacological treatments do result in a significant reduction in maternal hospitalizations. Likewise, reductions in preterm delivery rates have also been reported, and several studies have noted a small reduction in low birth weights and stillbirth. What is perhaps more significant is that no adverse outcomes for the baby have emerged. Taken together, this composite of benefits may help to allay any anxiety that the mother may have when being advised to take antihypertensive medication. Furthermore, it is not unreasonable to remark that a healthy baby requires a healthy mother. The medical interventions described so far are aimed at keeping the mother healthy.
In general, calcium antagonists such as nifedipine and beta blockers have a long safety history and are generally recommended as first-line therapies. ACE inhibitors should be avoided, but an important corollary to pharmacological treatments is that of a heightened awareness to changing upward blood pressures. In and of itself, this awareness tends to result in the taking of prompter actions, hospitalizations and interventions that ensure safer outcomes. Essentially, delivery of the baby is the cure for a worsening situation or an eclamptic catastrophe. The timing of intervention is nuanced and requires consideration by an experienced obstetrician who has to balance the risks of premature delivery with respect to both the mother and the baby.
If seizures occur, these need to be dealt with promptly using the airway, breathing and circulation approach. Oxygen, intravenous magnesium and intravenous antihypertensives such as labetalol. If seizures persist, consider using intravenous lorazepam. Cerebral imaging will be required if there is concern about a bleed or a subarachnoid hemorrhage.
So what of Mary's tragedy? She certainly had one of the recognised risk factors for eclampsia. That is, she was moderately obese. Diagnosing gestational hypertension and proteinuria is part of sound antenatal care. Preeclampsia, as defined here, could have been recognised and appropriate actions taken.
Not least of which, measures of fetal growth rate, consideration of fetal movements, and a focus on other biochemical and vasogenic markers may have been sought. Additional actions could have included behavioural modifications with clearer guidance. Aspirin and antihypertensive treatments could have been prescribed, and prompter interventions with early hospitalisation might have averted this catastrophic lightning strike. We can learn a lot from Mary's sad case.